space.
Good afternoon and welcome to the inaugural Health Equity Day sponsored by Sanofi with the Boston Globe. We're thrilled that we have a bunch of people here in person. Also to anyone who's online participating, thank you, thank you, thank you. It seems so interesting to still be talking about health equity, but we are so far from where we need to be. Obviously, this was an issue that was acutely brought to the public forefront in 2020. It was made obvious to a lot of people that where you were born, where you were raised, what race you are, what gender you are, can have a real impact on health outcomes. The question is, what are we doing about it? How are we moving from talking? And at Sanofi, we're really trying to take that next step forward. So we talk about chasing the miracles of science, but we also talk about transforming healthcare. And we happen to be in this ecosystem, the premier life sciences ecosystem in the world. And our hope is with our partners here, there's health systems here, there's other manufacturers here, there's academics here, we can start to put some really interesting ideas on the table that we can then move forward into action. And I think our first panel is going to be a really interesting first step towards that direction. We're very pleased to have Dr. Jha, who is the Dean of Public Health at Brown University. He was also appointed by President Biden to lead the COVID-19 task force, and he's going to be interviewed by the very capable Adam Fiore from the Boston Globe. So I'm going to turn it over into your capable hands to start the discussion.
Okay, thank you. And thanks, Dr. Jha. This is it's a great privilege to talk to you. As we were discussing back there, my impression from writing about health equity here is that there's been a lot of talk about the issue, but during COVID, it became, the health disparities were so apparent that it was a real crisis situation, and it catalyzed people into action in a way that maybe they hadn't before. So I just wanted to start by just hearing about your experience. I mean, so you were at the Harvard School of Public Health, and you had just signed on to Brown, and then you were tapped by President Biden to lead the COVID response. And so I just wanted to hear, sort of how you became aware that this was, a critical part of the crisis, and what that was like, and how you decided to tackle it, and what the Biden administration did and learned.
Great. Good afternoon, everybody. Thanks for having me here. So I think I and probably much of the country became aware of the huge disparities in not just who was getting infected, but who was dying of COVID somewhere around late April, May of 2020, as the data first started coming in. And it became very clear, people used to say, we're all in this together. Yes, we were all in this together, but we were not all in this together equally. And that, I think, became very clear then, but we didn't really fully understand what was driving it. New virus, we were still learning. And even in the months that followed, Adam, I just saw so many people in public health, and these are good people, smart people, well-intentioned people, make really critical errors in trying to address those issues. And I think one of the lessons I learned early on in this was we didn't always have the right people around the table when it came to decision making. I think about the fact that testing was being set up over the summer of 2020. Huge advocate of testing, I thought it was great. People were setting up drive-through testing. Well, drive-through testing is great, but you got to have a car to drive through places. And it was often set up in places where you couldn't just walk in. You couldn't take a bus to the testing center and walk in and get tested. So little things that you would know if you understood the communities where the virus was spreading, but otherwise all well-intentioned. So I think it really was clear to us by summer, fall of 2020 that this was a huge part of the problem. Moving forward, when President Biden came into office, he said publicly that he was very committed to having an equitable response. So what did that actually mean? And I will talk a little bit about what happened before I arrived at the White House. And then I'll tell you about a specific moment where the issue of accountability really came to my forefront. So in the early days of the Biden administration, it was all about getting vaccines out. And it was very clear. I was talking to the people in the Biden administration. It was very clear they were tracking vaccine distribution, vaccine access, vaccine uptake by race, ethnicity, rurality, certainly gender, age. And it was one of the first true national programs. If you look at Americans who got the initial 2-dose vaccines, there are no racial differences between whites, blacks, and Latinos in that. There was a lot of work that went into that. I arrived about a year later. Vaccine uptake was what it was. I started trying to get treatments out much more widely, Paxlovid and other treatments. And I remember a day, specific event, specific moment, I was in the Oval Office. By the way, I love being able to say it. It was an extraordinary experience. I know, I felt totally like I was posing there. I apologize. It's true, though. With the president, and we're talking about, like, the summer wave was starting to take off. And I was talking about how we were prepared for the summer wave. This is summer of 22. And I had mentioned how we had done all of this work to get treatments more widely available to the country. And he said, that's great. Are you making sure we're reaching everybody? And I said, oh yeah, it's in all 50 states, it's in all the communities. He said, that's not what I mean. And I knew what he meant. And what he meant, and this was part of my accountability as the head of the COVID response team, was everything that we did, vaccines, testing, treatments, we had to break it down by race, ethnicity, income, rurality, look for gaps, and if we found gaps, we had to close them. And I was accountable for that. And that at times was hard. It meant trying to be much more creative. And I'm happy to get into some of the things some of the strategies we employed. But for me, and I'll just finish with this, we've been talking about health equity for at least 20 years, probably longer. We talk about the drivers of health equity, the social determinants of health. Those are all really important. We should talk about those things. But at some point, somebody's got to be held accountable for closing those gaps. Because until someone is held accountable for it, it is hard to move the needle. There are deep structural differences in our society that show up in health, and we've got to find a way to solve those.
Okay. Yeah, well, were there any immediate sort of emergency interventions that you did to get up vaccination rates by race or treatments by race? Or, was there anything that you did, in the moment?
Yeah, so I'll tell you some of the stuff that happened that my predecessor did, and some of the things I did. Look, the issue is this. I think we're just going to start off with this, we have a deeply inequitable society, right? So any program you put in, people who are wealthier, people who have more social capital, they're going to utilize those programs more effectively up front. You just have to recognize that. So then you begin to say, okay, so how do we begin to address that issue? So let's talk about vaccinations. Early days, yes, when there was a scarcity, you could see the gaps. Over time, what you needed to build trust. So there was a huge national program with barbershops and other places in the African American community, because they are places that are deeply trusted. They are places where people go spend time. You can't just show up to somebody's door and knock on their door and say, hey, you should get a vaccine. Like, that's rarely going to convince somebody, but if you're someplace for hours, they know everybody in the community. So it was all about building partnerships with community-based organizations, with faith-based organizations. On my watch, when we were thinking about treatments and we could see the gap developing, one of the things I thought a lot about was the fact that in many communities, people don't have access to a primary care physician. So who do they access for care? Well, often it's the pharmacist in the community pharmacy. And so we, with the FDA, created a program where pharmacists could start dispensing treatments for COVID. That took work, but it was really important. And all of a sudden, we did that. We worked with, as I said, with community-based organizations. We looked at what communities had the lowest uptakes and went out to those communities and said, who are the people who are really influential here? We found in the South a lot of skepticism of anything the Biden administration was doing. So I realized I was going to be the wrong voice for this. We partnered with religious groups, both on the right and left, to start talking about the importance of vaccines and treatments if you get COVID. So it is a kind of an all-out strategy, but if you do it, what you see is these big gaps really beginning to close.
Okay. Yeah, I know from covering Massachusetts that there's a tremendous amount of momentum that came out. There was a crisis in terms of disparities in vaccines, and there was a group called the Health Equity Compact, which consists of people of color in healthcare, and they've been meeting, and they have a lot of momentum. It's there's some optimism that they might actually enact some lasting change. I'm wondering if you saw anything like that on the federal level, or there's other things that are sort of legacies of the COVID time that give us reason for optimism in terms of dealing with this intractable problem.
Yeah, good question. So I do think that there are some very positive legacies that continue today that I hope we can sustain. I'll also tell you there are things that we did really well in the pandemic that I worry we're losing. So CDC, for instance, built these really strong partnerships with community-based organizations that require resources. And as those resources have been pulled back, the relationships are still there, but you just can't sustain them because these community-based organizations have to function and they have to focus on things. So I worry a little bit about some of the pullback. But I think about one of my favorite organizations that I worked a lot with when I was at the White House. Was run by a guy named Reed Tuckson. It's called the Black Coalition Against COVID. For those of you who know Reed, he's an extraordinary leader in healthcare, has been for 30 years. His coalition is still going. And yes, they're still working a little bit on COVID, but they're also working on a whole host of other health issues. And that coalition is made up of health people, is made up of people in the entertainment industry, people in the sports industry, people in every industry. It was a true coalition. So we have those, and the question is, how do we sustain them over the long run to keep working on issues? Because there's plenty to work on. It's just that urgency and those resources aren't there in the same way.
Yeah. Let's see. So maybe we could just shift gears for a second and talk about some of the things you're doing at Brown that you're excited about in regards to health equity.
Sure. So I'll tell you about one thing that I've thought a lot about. So again, going back to April or May of 2020, or even over the summer, as I was watching, and again, the public health response, hampered by a lot of different factors. But one of them, and I alluded to this, was I became convinced that we did not have the right people around the decision-making table when decisions were being made in departments of health across the country. Again, I know a lot of the leaders of the public health departments. They're awesome people. They're really well-intentioned. They care about equity. But caring about equity and having real expertise on taking care of people in various communities is not the same thing. And so we started something called the Health Equity Scholars Program my first year as dean, which was a program where we bring in 10 scholars every year who are graduates of historically black colleges and universities. They get an MPH, they get really good sort of training and lots of other things, and then they get a lot of mentoring and networking. And the idea behind that program, and I tell this to each of them, and now we've had 4 years of these folks, is I want them to go do great things, and they're going to go do great things. But what I want is over a decade, 100 of these people out there, deeply networked, in the leadership roles, making a difference. And to me, that is a structural intervention in the field of public health. The workforce of public health is very diverse. The leadership of public health is not very diverse. And that is something we have to change, and that is not going to change overnight. But I feel like universities have an obligation to make that change. And if it takes us a generation, it takes us a generation. But we got to do it.
Okay. I don't know, let's talk about some of the social determinants of health.
Sure.
And I know that's something you've thought about and talked about. What are some things that we could do on the state and federal level, or just some areas we need to be paying attention to, do you think?
Yeah, I will make a point that I think we in public health often don't make enough, which is, we talk about social determinants of health. I think everybody in the room probably has a sense of what that means, all these social factors that drive health outcomes. It's a complicated story, actually, it turns out, because it's bi-directional, and here's what I mean. When people don't have housing, they don't have access to food, when they don't have job security, that obviously has a negative effect on health. That's kind of the idea behind social determinants. But the other part is, when people are sick and don't have access to good health care, it's hard to keep down a job. And if you can't keep down a job, it's hard to stay housed. And so this is actually very bi-directional. And so I often say, you want to invest more in housing? Please, let's do that. We've got to do that in Massachusetts. I work in Rhode Island, even worse in terms of the housing crisis. Those are important things. But one place we can begin is by making sure people have access to really high quality healthcare. Because if you can do that, you can allow people to stay in their homes, stay in their jobs, and that has all of these other benefits as well. So instead of trying to boil the ocean, we're going to solve all of society's problems. pick a couple of things where you can actually make progress. I think housing and housing policy is a really important thing. I will tell you, by the way, our governor here in Massachusetts has been awesome on this, really pushing communities to open up more housing, more affordable housing. And so that's one part of the health strategy. But the part that I work on, because I'm a physician and I think about health all the time, is we've got to make sure that we get really good access to high quality care for everybody.
And how did the Affordable Care Act affect this? I know that's something that you've talked about before.
Yeah, I think the ACA, and people have different feelings about the Affordable Care Act, and so a lot of people out there want to repeal the Affordable Care Act 14 years later. By the way, that is a crazy idea. It's not going to get repealed. But anyway, the point is it made a lot of progress. If you think back to where we were in 2010 when President Obama signed the bill, we had more than 50 million people uninsured. That number is cut by way more than half. And there are very large tangible benefits of getting access to health insurance. One of the problems right now is you still have 10 states, including Florida and Texas, that have not expanded Medicaid. So you still have millions of people who don't have access to health insurance in America. Totally unnecessary. That needs to be dealt with. But to put the health equity angle on this, Adam, the ACA, yes, it expanded insurance for lots of people. It disproportionately expanded access for African Americans, for Latinos, for other people of color. So it had a big equity effect beyond just a general health effect for the population.
Okay. I guess I'll ask you one more question, and then I'll grab some here from the audience. But do you have any thoughts on implicit bias and what we can do to reduce that? I mean, I know it goes both ways, but that's sort of an insidious part of health.
It's a very good question.
Health disparities.
We all have, by definition, some amount of implicit bias. I think there's a lot of work that's been done on how to train people and how to do. And I would like to see the data on how effective that is. But what I like to sort of focus on is what are things that we can do to standardize and take that implicit bias and make it less impactful. So here's what I mean. I do think, for instance, that there are a lot of places in healthcare where more standardization, and there are some challenges of this, which I'll talk about in a second, but more decision support for clinicians. What do I mean by that? Instead of every doctor at every point just trying to make their own decision where implicit biases will come in, creating guidances, creating programs that actually help physicians and nurses make better decisions. There are tools we can use to start overcoming some of those biases. The only warning on this, and there's a lot being done right now in healthcare with using AI to do these things. AI, we all have heard probably more about AI in the last year than we want to. AI is everywhere. AI is going to be an important part of our lives. AI really is built on the training data sets that go into feeding these AI models. And if the training data sets have biases in them, the AI will have biases in them. And we're starting to see that emerge more and more, where these algorithms and tools that have come out of these AI models essentially recapitulate all of the biases in our current system. So we have to be very conscious of that and make sure that we're not just essentially automating all the things that we have not been doing well in the last 10, 20 years.
Okay. All right, so here's a question from the audience. What community medicine initiatives exist or could be created to address the increasing pharmacy droughts in low-resource neighborhoods?
Oh, that's a good question. It is true that the local community pharmacy, which was such an important part of the American healthcare landscape, has been slowly but surely going away. We've seen obviously the rise of these big chains. That's fine. I use CVS next to my house all the time. I don't have a problem with that. But the point is that there are communities in which the local pharmacist and the local pharmacy was the most trusted place for healthcare. That has increasingly become harder and harder. I do think from a policy point of view, pharmacists probably represent the most underutilized part of our healthcare workforce. Pharmacists know so much, can do so much more. And we need to do a lot more from a policy point of view. I'll tell you why it will address the question that this person has asked. If we allow pharmacists to be able to do more basic primary care, to dispense medicines, to actually prescribe a limited set of medicines, and then find ways of reimbursing them, what you actually do is create a business model where those community-based pharmacies can actually thrive in those communities. So I think there's a lot to be done on the policy end. Everybody always worries, are these pharmacists going to be really trained to do it? Pharmacists are, as I said, extraordinary healthcare providers, and I think if we do more to empower them, it'll improve access. It'll also make it a business model that's more sustainable.
Okay. Let's see. Well, what metrics have we developed to better quantify our progress towards health equity? And are there other U.S. cities from which we can learn?
Other U.S. cities. Well, let me start by the first part of the question. Look, again, there are lots of ways of thinking about health equity. I don't have a simple one-line answer on that. But for me, for my entire career, I have believed that you got to look at the data and you got to stratify data by the groups that you're particularly concerned about and look at it. And so during the COVID pandemic, when I was at the White House, what were the metrics I was tracking? Certainly on one end, infections, hospitalizations, and deaths stratified by race, ethnicity, income, rurality. And on the other end, tests, treatments, vaccines by race, ethnicity, income, et cetera. So the point is, because if you don't do that, if you don't look at it broken down by groups, you have no idea whether you're making progress or not. And then making sure you're holding people accountable. But you can take that model and apply it to almost every maternal mortality, opioid overuse, and opioid deaths. One of the things, by the way, that we talk very little about, there has been this huge shift in the demographics of who is dying from opioids in the last 5 years. People are largely not aware of this. In the last 5 years, the death rates among African Americans has skyrocketed from opioid overdose and has overtaken death rates for whites by a pretty substantial number. And it has largely gone unnoticed. And in people's kind of mental model, this is still a problem that's primarily affecting the white community. Obviously, it's a problem for everybody. I don't in any way mean to suggest it's not. But there is a real angle of health equity here that we have largely not paid attention to because we're not always breaking down the data the way it needs to be broken down.
Well, what's driving that, do you think?
I don't know, actually. It's a very good question. I've talked to a lot of people who study this, and I think a lot of people are puzzled. We saw this clearly start in the middle of the pandemic, but it has just continued as the pandemic has waned.
Okay. Let's see. Can you say, actually, you kind of just answered that question. So the final question, how can an average consumer help combat inequities in the healthcare system?
Oh, that's a good question. I'd be curious what other people think about what the... So when I think about things that are going to make a difference, right, we've talked a lot about making sure people have access to healthcare as one thing that we can control. I think that is still a question that as a country we continue to debate. I personally believe that everybody needs to have access to healthcare in America. That just should be a right of being an American. But that is an ongoing conversation, an ongoing debate. So I think pushing our political leaders on that, I think when you think about the health systems you're a part of, looking at their data, pushing them to have more data out there available by race, ethnicity, advocating for policies that are going to drive improvements in equity. Part of it has been that I think we have not taken this on as a cause that all of us are pushing for. This is not a niche problem that one group is going to solve. I think if we take a more of a collective approach to solving this, I think we really can make a difference.
Okay. Well, thanks for your time.
My pleasure. Thanks for having me.
Now I'll hand things back to Deborah Glasser for Santa Fe to close us out.
I get the very quick honor of closing out. So first of all, thank you for the lively conversation. We hit on AI a little bit over lunch with a smaller group, and it was the same conclusion about the biases that are going into those data models and are they feeding out those same biases. Thank you again. Wonderful conversation. We're going to turn it over to our colleagues and friends at Takeda, who are going to lead us through our next conversation on community health workers. So thank you so much.